Welcome to the Break the Cycle podcast. Today's guest is Dr. Gil Hoftman. He is a adjunct assistant professor at the UCLA Psychiatry School and also has his own clinic, Helix Psychiatry. He is primarily a child psychiatrist, an MD, and a PhD. And today we'll be diving into all things child psychiatry, TMS, and how you can use these innovative treatments to transcend all sorts of indications, depression, all other sorts of things. So join us on today's episode. Dr. Hoftman, thank you so much for joining us today. Welcome to the Break the Cycle podcast.
Thank you for having me.
You are an MD and a PhD, is that correct?
Yes, I am. Yeah.
Amazing. What made you pursue both? Most just go for one.
Yeah, that's a great question. Yeah, I think I always kind of knew that I wanted to be a doctor ever since I was little. I know there are some stories like that, right? Where people are like, oh yeah, I wanted to be a doctor. There's actually video evidence of me when I was in kindergarten as a king of the day. And they had us sit there and the teacher was like, hey, what do you want to be when you grow up? And of course I said, I want to be a doctor. This is like 5 years old, right? Yeah. And of course it was like just a 5-year-old understanding of what a doctor is with a Fisher-Price kit, like taking care of my mother.
Yeah.
But as I continue to grow up, I don't know, something in me always felt like, hey, I want to be able to take care of people who are in a vulnerable state, who are feeling sick. And as I kind of grew up, I started liking science also and really got into neuroscience as early as high school. I would read my older brother's medical school books I'm a very big nerd about that, by the way. If you didn't get that, right? So just loved it ever since I was little. And would spend whatever time I had left after school and after playing soccer, which we talked about a little bit, reading about neuroscience. So I think there was always kind of, I like people, I want to help people, but I'm also really interested in the brain. And so long-winded way of saying, once I got to college, I still liked both. I learned about an MD PhD option as I was working in a neuroscience lab. And that sounded like a great path for me to be able to really go in depth into the science and maybe creating new knowledge and then also being able to take care of patients.
Yeah, I think it's interesting. You have a PhD who is, I feel like, up that ivory tower and they're looking at like publishing papers, which is really important. But I think sometimes there's a separation in between a PhD and then a doctor who's actually applying the medicine and then being able to have someone that understands kind of both sides on like the rigor of the research, but then also the application and the human side, which is amazing. So then at what point, because you're a child psychiatrist, but you treat all ages. When did you start to look at that patient population? You were like, that's interesting to me. I want to pursue this further.
For sure. Yeah. So I've also always loved children, like interacting with children. I remember as an undergrad, even I volunteered at the Children's Hospital as a child life volunteer. I don't know if you know the child life specialists, but when they're at Children's Hospital, they're tasked with basically playing and providing toys and all kinds of fun activities when the child is hospitalized. So they kind of take their mind off of the fact that they're in the hospital.
Sure.
And so there are child life specialists who do this, and then they have volunteers who also help. So they have like a toy room, playroom area. They bring people to the kids' rooms to entertain them and to hang out with them. So I started doing that as a college undergrad, really loved it. I would bring my guitar to some like kids' rooms and we'd play music together. I mean, I remember a kid who had like a multi-organ transplant and still had IVs attached to him, would come to the playroom and all he wanted to do was roughhouse. And he would like try to wrestle with me. I'm like, okay, how far can I take this without like injuring him? Right? But it was just so much fun, And so from a human standpoint, I always loved kids in general. And then again, this weird theme in my life is like this integration between like really loving the science. So I loved development and I thought brain development was so fascinating. How can we go from a cell to humans? And then how can we go from, being born practically helpless to within a few years, like walking, talking, having emotions, having like thoughts and like being pretty smart already. And then that just continues to develop throughout our life. So that was fascinating to me. And that kind of pushed me toward child psychiatry as opposed to, staying on the adult end. And I mean, I have not regretted it at all.
That's amazing.
Yeah.
And I think there's a lot of conversations around prescribing medications to kids, amphetamines, Adderall, antidepressants, right? The first time I heard like a child was on antidepressants, I was like, how does that work with a developing brain? What are your thoughts on those pieces, on prescribing at a younger age?
Yeah, I mean, just like any intervention, I think you have to be especially thoughtful and really think deeply about, risks, benefits, any sort of options for treatment, and what the side effects can be, right, in the context of development. And so when you're looking at children, when you're looking at adolescents, I mean, that's just such a key component, right? It's like, how are they developing? What kind of risk does this have for them? Not just medication, but any sort of intervention, right? And what's interesting to me also, there seems to be often double standards between, other branches of medicine versus brain medicine, and the role of medications, right? Oftentimes we say, okay, if the kid has asthma, they should get an inhaler, they should get medication. Depending on the severity, they should get more or less, including steroids, which have an impact on development, right? But it doesn't seem like we necessarily scrutinize that as much as we do like an antidepressant or a stimulant. And maybe that's because we're concerned when we know a medication acts directly on the brain versus when it's acting on other parts of the body and maybe indirectly. Yeah. And then on top of it, right, in a lot of cases, we don't necessarily know the long-term outcomes. We don't necessarily know in a rigorous way, what the true risks and benefits in the long term is, right?
Yeah, it's hard to study that. How do you, this group of individuals have taken it, they haven't. And on a one-to-one, and what metrics do you look at?
Yeah, I can imagine that with the testing for antidepressants, like a lot of them, the studies were done on adults, right?
This is true, although there have been some big studies, NIH-driven multi-site studies for treating depression in children and adolescents. And the two main medications that were looked at initially were Prozac and Lexapro. And they did outperform placebo, which is why they got FDA approval, really all the way down to, I think, oh man, I have to double check, but like single digits, like 6, 7, or 8. And then there were some follow-up studies for treatment resistance where they looked at things like selective norepinephrine reuptake inhibitor, SNRI, like Effexor, which was no better than SSRIs. So there are data out there to guide us in terms of benefit and tolerability. But again, in terms of long-term outcomes, much more limited.
Yeah.
Like, do they check back in with those?
From a study standpoint, the way our studies are set up in the US, it's much harder to do like long-term longitudinal studies. Yeah. Because the funding just doesn't work that way.
Right.
So we don't have good long-term studies from that standpoint. You'd have to go to Europe to look at those through the registries. So I think there's a lot more work to do to really get a good sense.
Yeah. Obviously, we've been talking a lot as well about like, exogenous substances and medications, so on and so forth. Like, what other components do you see as like a child psychiatrist that are integral in order to see like results within children?
Yeah. So I always say, writing the prescription is the easiest part of psychiatry. And it's also probably almost like the least important part in the whole process, right? And what I mean by that is that there are so many critical components, not just in evaluating a kid who's struggling, but also thinking about the kid in the context of their family, in their context of their schools, just in the system itself, because a kid is highly dependent these different systems in these environments that they're spending much of their time in. So some interventions that are highly effective in many cases are things like family therapy, like family-focused psychotherapy, where you can really get into these basically habit responses, these interactions that people have, and patterns of behavior and communication that are not adaptive, that are, driving behaviors and maybe driving, the appearance of conditions like depression or anxiety or aggression or agitation. And so even things like, having a better understanding of the family structure, having a better understanding of their home environment, making school accommodations, or having a better understanding of how things are set up there can have huge impacts before you ever consider medications.
Yeah. And as a psychiatrist, I mean, obviously you have your tools with medication, and we'll talk a little bit about TMS as well. How do you kind of gauge what that environment is? Because I would assume that it would be almost like more of a therapist kind of standpoint.
Yeah, it's a really good question. Like the discernment between, like you mentioned, like these patterns that maybe appear or present as like depression or anxiety, but really it's just like interfamilial, like family pattern or something.
So true. Yeah. I mean, I think what we call depression and anxiety and these are just very heterogeneous, just like very mixed kinds of conditions.
Yeah.
Right. Some appear to be more like maybe biologically driven, while others are much more environmentally driven. And then within the environment, they could be driven by so many subcomponents of the environment. But the question about, as a psychiatrist, it's really critical to have integrated teams.
Yeah.
Whether that's within your own clinic or whether you really spend the time communicating with therapists, with school officials, whether it's the teacher, the counselor at school, the nurse, right? And also understanding and really talking to the parents about other siblings. So sometimes behavior is driven when there's another sibling who, may be struggling or maybe requiring a lot more attention. And then the sibling who does not get attention may develop certain types of behaviors. And that doesn't necessarily mean they're depressed or anxious, but there's a huge imbalance.
Yeah. The parents and the family are such a variable in the child's mental health state, and to just look at it as like kind of like, take the medication is not looking at them as like holistic beings, One thing that you spoke to regarding kind of your residency at the hospital is like wrestling with, these kids that had multi-organ transplants, but it almost satiates that like innate human and child like desire to play, right? And to be like interactive and engaged with others. And maybe children could be depressed just because of the deprivation of that alone.
I completely agree. One of the things that was just so striking to me, and I think one of the things I really love about children is just their raw like honesty, right? And oftentimes the lack of like feeling sorry for oneself, where like, these kids could have been on death's door, but the second they're feeling better, they want to be a kid and they want to play and roughhouse and everything like that, right? So I think keeping that in mind, this is for everyone, not just for kids, keeping in mind a human being's innate resilience and innate ability to heal themselves, I think is a critical component of approaching people medically, and especially psychologically or psychiatrically. You don't view them, to me, you don't view them as this just strictly biological organism that needs to be tinkered with and balanced electrochemically per se, right? We have tools to help with that. But that's not what a human is, right? So you, like you said, you think of people holistically, and then you can get a better sense of what might be helpful for them, especially if they're kids and adolescents.
You talk about the electrical chemical imbalance. We're talking a lot about the chemical. Can you talk a little bit more about the electrical? Because you have a background in TMS. What is TMS? And then also its applications on adolescents.
So TMS stands for transcranial magnetic stimulation. And if you break down each of the words, what transcranial means is that you put something outside of the skull to change something inside of the skull, right? So you put a device outside the skull to change brain activity inside of the skull. And the skull is kind of like the intermediary, the barrier that is often makes it very difficult to access the brain. So that's the transcranial. Magnetic, this is critical for the treatment because the way magnetism works is if you generate, alternating magnetic pulses, what you can do is generate an electric current in the tissue. And so you don't have to send these like intense electrical zaps like you may have to do with a different shock therapy. You could be much more gentle and induce the changes in a gentle way over time. So that's a magnetic part. And stimulation is you're activating the tissue, whether you're actually exciting or inhibiting the tissue. It's still kind of a stimulation. So that's what TMS stands for, right? If you think about your brain and a lot of different cells in your body, I mean, they are electrochemical in nature, right? So your brain operates on these electrochemical gradients, and it's a very active organ that changes all the time, right? And so if we have ways of helping change maladaptive patterns of brain activity in ways that are tolerable, and you don't have to go under anesthesia or it doesn't give you horrible side effects, well, then that's a huge tool that can help so many people potentially, right? And the way I see the brain, and again, it's probably way too simplistic because our brains are so complex and we understand so little about them, but it's really, we have neural networks, right? These are cables and living organisms that are connected in many complex ways and are distributed and all interconnected. So, it's like we talk about brain regions, we talk about receptors and chemicals, but this is when things are working well, just like with your body, integrated structure. So when you touch one part of it, you're really affecting the rest of it.
Yeah. Really interesting. And then its application to adolescents, like we work with a bunch of different clinics, and the biggest indicator is treatment resistant depression, meaning that they have failed a few different antidepressants and they're qualified for this treatment. Is it the same with adolescents? Is this treatment safe for adolescents? Can you speak more to that?
It's a good question. Yeah. So there's so much to unpack with the language that we use for this, like the idea of treatment resistant depression, right? It seems to be a construct that was really, it's really developed by insurances in a way to allow for financial coverage of an otherwise expensive treatment, right? So is depression that's resistant to SSRIs or antidepressants, like what exactly does that mean? Is that something like completely different? So we could get into that, and we could probably talk about that in a whole different segment. But let's just go with that, right? And so then we say, okay, TMS, right? But now we're talking about, okay, well, what about the developing brain? What about adolescents? What about children? There were recently really good kind of real world studies. So they're not randomized, they're not blinded or really controlled, but there's a lot of data that has been accumulated over time through clinics, basically, who are treating adolescents, and basically all the way down to age 12 in most clinics. And because of all the data that showed benefit and safety and tolerability, the FDA decided to clear TMS treatment down to age 15 now. And this is for 2 devices right now. Basically a figure 8 coil device, which is one type of TMS that sits over whatever you're targeting, and then a different kind of coil which looks like a helmet, which stimulates more broadly. So there are 2 devices now that have the clearance down to age 15. And it was even safe going down to age 12. There just weren't enough subjects for the FDA to say, okay, we can clear this. So it seems to be promising in terms of a data standpoint and in terms of safety for adolescents at this point.
Is that just for depression in adolescents, or?
This is currently for depression, and it was, I think for one of the indications, it was approved as basically like a first line and adjunct type of treatment. So technically in adolescents, it can be used even if they haven't failed antidepressants.
And will it be covered by your insurance?
That's the other question. So
Okay.
Insurance, I think that may take more time
Yeah.
for insurance to cover it. What I've heard is that some insurances have basically taken their adult criteria
Okay. And moved it down.
and just moved it down. Yeah. Instead of 18, they crossed out and put 15. So you still need to fail like 2 antidepressants.
Okay.
You had to have therapy. Others have actually modified it to say, oh, you need to fail 1 antidepressant trial. So make it a little more accessible.
Yeah. And have you treated any adolescents with TMS?
Yes, I have.
And do you have any like success stories, or do you have any like anecdotal experience from that individual?
Yeah, definitely. Yeah, I could think of a couple of individuals who, started showing benefit within, say, like 2 to 3 weeks, showing improvement in their anxiety and their mood. So like the general distress levels went down. They started feeling kind of a bit more motivated, which is pretty interesting to see pretty early on. We're sleeping a bit better. We're able to go back to school. Initially, like some of them were out of school. And I've talked to some colleagues who have been deploying different protocols. So there are newer protocols where you can use a different type of stimulation and stack it within one day to give multiple treatments in a day.
Yeah.
So it's called an accelerated TMS protocol, and different people do different forms of that. And you could finish a treatment within 5 days or 10 days, as opposed to within like 7 or 8 weeks.
Mm-hmm.
And so in some cases where there was severe depression, I was talking to some colleagues who have been deploying this. The kid was out of school already. They did a week's worth of these accelerated protocol treatments. And then within a week later, they went back to school and were continuing to show improvement over time. It was really dramatic and really well tolerated.
Mm-hmm.
Almost hard to believe, honestly.
I mean, yeah, you talk about like a developing brain. I would almost think that, not that it's more plastic, but like there's almost like more stimuli going on, and you're developing at such a quick rate that maybe, on that type of brain, it's maybe more malleable or something. I mean, I'm not a neuroscientist, so I have no idea, but.
Yeah, no, but you're intuitive, right? I mean, I think that makes a lot of sense, and it would be interesting to kind of see over time if that ends up being true or if we can test it in some ways. But you would imagine, right, that if you're applying TMS to someone who has had depression for 30 years and has struggled for 30 years, that it may be harder to change those brain patterns.
Mm-hmm.
Even if you get early response,
right,
it may go back or it may take longer. Mm-hmm. Imagine someone who's only really been struggling with that for a few years and haven't had a lifetime of that type of brain activity.
Yeah.
Right.
You would imagine that may be, like you said, more malleable, more plastic to change.
Yeah. And one thing that you were speaking to earlier was being able to kind of potentially test out the stimulation during different states of neuroplasticity, right? And what's the best way to be neuroplastic? It's probably to be a child, right? So I'm curious, what's the research based off of like the efficacy of the response based off of neuroplasticity and how malleable your brain is?
Yeah. So I think that's an active area of research.
Yeah.
Again, very, very intuitive observation that makes a lot of sense, right? So there are a number of labs in the country who are looking at different ways of optimizing plasticity, right? And so we know certain ways exist, right? So we know that, for example, that during deep sleep, non-rapid eye movement sleep, so NREM deep sleep, that's a time where your brain is highly plastic and like processes things that maybe happen during the day, and so you can really potentially intervene during that time and get a bigger response, right? Other people are trying to augment certain neuroplastic like pharmacological agents, like D-cycloserine is something that's been studied that's kind of helps the NMDA receptor, which is like a specific receptor that's very important for learning and memory. So it helps it become more active. Some people are using stimulants, and with psychedelics, maybe that'll be a new window for neuroplasticity that if you pair TMS with, you might be able to get a better response.
Yeah, super fascinating. Are there like baseline side effects for adults and adolescents when it comes to TMS? Are they exactly similar? Are they different in any way?
Yeah, so with a caveat, they appear to be the same, basically. The same kind of risk and same kind of side effects. The caveat is that there's just the number of adolescents who have been treated and studied are just much smaller than the number of adults. So you always have to be cautious when you have smaller sample sizes, because anytime you roll out any sort of treatment to bigger and bigger populations, you learn new things, right?
Right.
So at this point, there doesn't seem to be any difference in terms of safety, tolerability, kind of side effects, and even benefits at this point in adolescents versus adults.
Wow. And then what adolescents do you see to be like a good, I guess, prospective patient for this treatment?
Very good question. Yeah. So this is important. So for any treatment also, we were talking before about, how do you approach children, adolescents, specifically for children and adolescents. I mean, you just have to do a very detailed assessment and to understand as much as possible about their contexts and their background and their biology as well, to give them the best chance of benefiting from a tool.
Yeah.
Right. And so for TMS, for example, one of the things that you would be a wild card and, would potentially make treatment a little more difficult would be, one, if they're having some sort of psychosis, right? So if they're losing touch with reality, psychosis is basically when people have hallucinations, which they're perceiving stimuli that aren't happening, or they have delusions where they are just have these, fixed beliefs with high conviction that don't change even in the face of evidence and cause significant distress for the person. And then they have thought disorganization. So if they have those kinds of things, they may not be a great candidate.
Yeah.
If there's a significant history and early signs of bipolar disorder, then you have to be very careful.
Yeah.
Right. If they're actively suicidal, so TMS may reduce suicidality by helping with depression, but if they're actively suicidal, right, you don't want to treat them outpatient. They may need to go to the hospital.
Yeah.
So things like that, you really have to look out for. But as far as depression itself and depression symptoms, there isn't a clear separation of saying, if they're more having trouble with like sleep or appetite, then they may benefit more, versus if they're having more like ruminations where these negative thoughts are swirling in their head over and over and over again, or they're having like really negative thoughts and feelings about themselves, or they're really low. We don't have that breakout yet.
Okay. It's relatively safe and well tolerable.
Yeah.
TMS. So I'm interested if a child comes into your office, hasn't taken any antidepressants before, expressing anxiety and depression, are you first to put them on a medication, or at what point does TMS make sense to be first line after X amount of antidepressants? Like how do you kind of go through? I'm sure there's so many different variables, but
yeah. But to make it simple, I mean, the way I think about it is, again, to me, TMS is becoming a clearer, safe and effective tool for people to use. So I'd like to present it as an option. And so if folks have the desire to really use TMS and it's appropriate in the sense that they're having depression, they don't have, so there are other things to think about also. They can't have certain like implanted devices close to the coil, right? So there are certain contraindications, but if they're appropriate for treatment, then I would offer it as a first line.
Oh,
you know,
wow.
especially for people who, you know, are strongly, you know, don't feel right about medication or can't tolerate medication. Maybe they've tried medications not related to psychiatry, but they really just are strongly against it, right? It'd be nice to offer a tool that's not medication based. And maybe they're already doing therapy, or you could combine it with therapy.
Yeah.
Right. Now, I don't know that that's, I mean, I guess now down to age 15, that would be considered FDA cleared. You know, so that would be considered on label. It's expensive though. So, you know, the families would have to have the means, or would have to work out, you know, kind of a you know, a specific kind of deal with the families to do that.
Yeah.
Yeah.
So you'd present it as first line, and if maybe they're looking for a medication-free treatment, it could be a really good fit, just depending on pricing, and then also getting to the clinic 5 days a week for 6 weeks.
Right, exactly. Well, and also, again, if they're not using insurance, we could do accelerated protocols, which would then, you know, it's technically considered off-label at that point, right, in that age.
Right.
But based on clinical experience so far, there's no reason to suspect any sort of safety or tolerability issue. So we would be able to be more flexible in terms of how to match the treatment to the family and the patient.
And have you done an accelerated protocol with adolescent before?
So I personally have not had the opportunity to do the accelerated protocol with an adolescent yet. Yeah. Maybe next time we talk.
Yeah. Or if I have a child. No, I'm just kidding.
Yeah.
Like, I'll get cooking.
Yeah, get cooking. See you in about 15 years.
Yeah, exactly.
We were talking about some of the off-label uses of TMS earlier. What other things do you think TMS is effective for aside from depression and anxiety?
Yeah, so there are a number of things that it is being studied for and used for in an experimental fashion. I will say one important thing for everyone to know out there, for us to know and hear also, is that, you know, you really have to be thoughtful about off-label use, right? For multiple reasons, right? One is that you don't know enough about it, or you don't have enough data to really be able to say to a person, you know, whether it'll be effective,
Sure,
and what level of safety there is. Two, there are ethical implications, right? You know, sometimes if people have tried other things and they're coming to you for off-label treatment, they may be willing to do things pretty much without thinking about it, and willing to like throw money at you. And, you know, so there are serious ethical implications with that. But if you're able to do it thoughtfully, maybe have some data, even if it's not established or great data, and do your informed consent in a way where the people are really saying, you know what, we want to do this, you know, then you can, I think, from my perspective, it would be reasonable to offer something. Because, you know, honestly, it's like, how do we learn new things about medicine in the first place? You know, people have to try things, you know? So you just want to make sure that you do it in an ethical way. So then getting more specifically to your question, I think it's really important to
caveat,
right?
Sure.
You know,
some people are just like,
let's
guys,
do
no
it.
breaks.
Yeah,
And you're like, whoa.
Yeah, I'm like, let's just be
That's a developing
let's
break.
not be all brakes and no gas either, right? You know, we gotta be somewhere in between.
Speed limits,
exactly. So some off-label uses that you know, I've been a part of. One is treating neuropathic pain. We know neuropathic pain and depression go alongside each other, right? Chronic pain in general. Pain can worsen depression, mood states can worsen pain, chronic pain can cause depression, you know,
comorbid.
Exactly, right?
It's like a biofeedback loop.
Biofeedback loop,
Depression
it's your
causes
nervous system.
pain in the body.
Right, yeah. Yeah, exactly. Right, so deploy TMS. Try to help with that. Some people will benefit with a reduction in the severity of pain, frequency of pain. Other people may not actually feel a difference in the pain itself, but because of the treatment, especially of like certain parts of the brain, like prefrontal cortex, it may not grab as much of their attention and cause as much suffering. which is a big deal also.
Huge.
Right? So it can improve their quality of life despite the pain still being there the way it was before.
Yeah.
So that's one option. There are studies looking at depression and fibromyalgia, which is kind of like, it's not neuropathic pain, but it's a different kind of pain. Depression and chronic fatigue syndrome. And then tinnitus or tinnitus is another kind of off-label treatment.
A lot of people comment on our videos asking about treating that.
Yeah.
That's so
Can
interesting.
you explain a bit more?
Yeah. So this is just such, first of all, people know tinnitus or tinnitus is this ringing in the ears. It's just incessant ringing in the ears that can occur from different types of damage. It could be like hearing damage. It could be, kind of chemical metabolic issues. And what happens is that people can get different kinds of sounds that occur in their hearing without a stimulus, right? But it's usually kind of like this high pitch. If you were ever at like a loud club or at a loud concert, and then you take that loudness away, you may experience ringing in your ears, and that's for tinnitus, right?
Yeah.
If you do that enough, it may not go away.
Permanent.
Versus-
Yeah.
Oh, I'm
Right.
fucked.
And that,
I'm like,
right? Oh my goodness, man.
Lady Gaga, too big in the ears,
I think I'm
too
starting to hear
loud
it
in the
actually.
ears. One too many fame balls.
Oh my God. I went to like this like live music club, very small club, and saw the band Filter there. I'm kind of dating myself. And they're like a band in the 90s that's like really loud.
Yeah.
And the speaker was right next to my head, and it was a great show, but I think I probably lost like a bunch of hearing.
Yeah.
And my ears were ringing for like 3 or 4 days after that.
No way.
Because it's never
Wow.
going to go away. But that is tormenting. And when it doesn't go away, it can drive people to suicide. It's no joke.
wow.
Oh my
It can
God.
drive people.
I mean, you can
to kill
imagine just
themselves.
ringing in your ears.
Yeah.
Holy shit.
Did you go home and just hit yourself with
at
it?
that time, I was
Wanded
still
up.
a
Bang.
medical student, so I
Okay.
didn't have TMS access. Now I might put TMS on myself.
It's like the nurse comes in. What's up, doc? What happened? I just loud concert.
You know what's funny though is that you were saying that like TMS isn't good for people that are like hearing external stimuli that's not there, but then actually when it's tinnitus, it's actually a good thing for you.
That is a great point you bring up. There are these seeming contradictions. This is true also for seizures.
Yeah.
Where TMS has a exceedingly low but still risk for seizures. That's the ultimate like bad side effect.
And I think that's like also a really strong misconception on like, if I put anything near my brain, I'm going to have a seizure and die.
It's a big fear for people, oh my God, is it going to cause a seizure?
Yeah.
Right. In fact, the studies show that a seizure would happen in less than 1 in 30,000 treatments, which is less than most medications you'll ever take.
Yeah.
Just to put it in context.
Wow.
So it's very safe from that standpoint. This is in adults.
Sure.
The adult data. But it's also being studied in like little kids with seizure disorders to treat seizures.
Oh,
Okay. Another contradiction or paradox is that a side effect of TMS can be headaches.
yeah.
But there are protocols that are being used to treat migraines.
Right.
Right. So it really just depends on the stimulation protocol in the person.
So that's off-label uses, right? So
Off-label.
headaches,
Tinnitus or tinnitus.
I'm just saying
Chronic
tendinitis,
pain.
but that's not it.
Chronic fatigue. That
Chronic
makes
fatigue.
sense, right? Because of the stimulation, just in general, which is why it's not good for people with mania, right? It's because they get like stimulated and more energized to take it, right?
Yeah. In some protocols, yes. And then there are other protocols that try to decrease activity in certain brain areas. But again, the brain is all interconnected. So even if you send like a stimulatory protocol to like the surface of the brain or inhibitory protocol to the surface of the brain, other areas in your brain may be activated because of that. And so really the net effect is what you're looking at. And in order to understand that, we have to have a better understanding of the circuits.
The question that we get a lot is autism and TMS.
Yeah.
There's some providers that swear by it. They're doing it all day, every day. Other providers that are a bit more bearish on it and not as maybe forward.
Yeah.
Where do you stand? And then can you explain a little bit more about like the uses of TMS with autism?
Yeah. I mean, the research is very mixed at the moment, and it's mostly done in adults with autism, although now I think folks are also trying it in younger people. So that becomes an issue too, right? Because an adult with autism has had that for a while, and maybe their neuroplasticity isn't quite the same as a child or adolescent, right? As we were talking about earlier. But yeah, people are very interested in it. It kind of depends also what domains of autism you're targeting. Are you targeting like social reciprocity? Are you targeting, kind of agitation? Are you targeting anxiety related to it? Are you even targeting, language, which some people are trying to target with deeper TMS and having, anecdotally some success?
That's
It
cool.
seems
That's
like
great.
people are talking
For, like,
more for
nonverbals?
younger.
Yeah.
For
So
younger.
that has to be like 5-6 years old. Yeah. Like,
Yeah, or even young, like early adolescents.
Okay.
Because they're gonna often stay nonverbal unless they get good interventions,
Okay.
right? Or their verbal ability will be limited. And there's some kind of anecdotal evidence that it may help in that domain.
yeah.
But the big issue is that there really isn't much that we have to treat autism. There really isn't anything like from a medication standpoint that we really know of that treats core features of autism. What we do is when it's severe, we treat the agitation and aggression, and then we treat comorbidities like the severe anxiety or the depression.
Neurodivergence is like a very interesting thing right now. Everybody like in tech having this kind of orientation that they're like hyper intelligent too, because they are, right?
Yeah. And everyone's like, oh, they're just tisming out. You know what I mean?
Yeah.
Like, it's just thrown around so easily now.
I think it kind of goes to like, just being able to like embody yourself too as your like just innate state, and kind of what you were speaking to prior about how like a lot of these conditions, it's not necessarily like a biological indication. It could be a circumstance of your life, and like how do you transmute that and metabolize it and turn it into like even a strength in some capacity, right?
Yeah.
But yeah, it's all super fascinating stuff. And
I agree with you. The whole idea of neurodivergence, I think, we know that people are different and think differently and like and feel the world differently, and that's the beauty of humanity, right? I mean, we shouldn't all be like monolithic and approach our environment and problems and solutions in the same way, right? How would we ever discover new things? How would we ever improve things if we all thought the same way, right? So neurodivergence should not be thought of as a disorder. Where it becomes an issue is if whatever you're experiencing is causing significant distress to you, affecting your quality of life, not allowing you to do the things that you want to do in your life, and that, you have to be a little careful about that, because sometimes it's, your environment is a mismatch to you, right? Our schools are very specific, right? And they may not match people who need more activity or who think differently, right? And so then there's pressure to put those people on medication, which, I think, I feel you get into like this system issue where you get stuck, it's like a disservice, right? You don't want to just put people on medication because they need to get through school.
Yeah. We have care coordinators that they'll talk to prospective patients and they'll be like, I've been on medication since 14. It's been 14 years now. Like, I want to get it off. What is the best way? And they're turning to TMS, which is really amazing. As a med-free option, and also the ability to taper off these medications. This has been such an amazing chat. Where can people find you? Tell us more about like your clinic.
Sure.
Yeah, because I think if I was a parent that was concerned with my child, you feel like the perfect place to send a child / be able to support them.
I appreciate you saying that. So I have a clinic called Helix Neuropsychiatric Center. It's located in El Segundo, California. So I have a physical clinic because I think it's important to see folks in person as well. We have hybrid options. If people want to get in touch, you can go to www.helixpsych.com. It's HELIXPSYCH.com. A lot of letters that people don't usually use.
I appreciate you spelling it out, because as a dyslexic, I'd be like,
right, you're like, oh God, how am I going to do this?
The fourth try, I'm like, I'm done. I'm done.
You're like, I'm not going here anymore.
I'm like, let me try Siri. Nope. Okay. We're out of here.
Exactly. So feel free. You can learn more about me, the clinic, what we have to offer there. You could also call 424-944-8549. I love spending time with my kids and my families, and it's really a privilege to work with folks.
I like that you say my kids and my family.
Yeah, my kids and my family.
Yeah,
exactly.
That's awesome.
It's really amazing.
Well, thanks for bringing so much light to the world and helping these children kind of transcend their traumas and their conditions, and for joining today's podcast.
Yeah.
Thank you for having me. It's been so much fun.
Amazing.